Federation of Asian Nutrition Societies Award in 2019, Dr. Gopalan passed away after 100 fruitful years of the life on 3rd October 2019. The Gopalan Oration Award is given every year to an expert who has made significant contribution in the field of nutrition and allied sciences. And the Nutrition Society of India is proud to announce that the 44th GOPALAN Oration 2020 will be delivered by Professor Christopher Paul Duggan on race, caste, nutrition in the 21st century, select studies in maternal and child health. So congratulations to Professor Christopher, and Dr. Anurag Upar will introduce the speaker. Thank you.
Thank you.
Thank you. It's such a great pleasure for me to introduce Dr. Christopher Duggan. He's an MD and an MPH, a graduate of Dartmouth College, which is an Ivy League college, and then the Johns Hopkins University School of Medicine, where he trained in pediatrics, and then he trained in nutrition and gastroenterology at the Boston Children's Hospital and clinical epidemiology at the Harvard School of Public Health. So Chris has come through all the best colleges, and his research interests include the nutritional management of acute and persistent diarrhea, clinical trials of micronutrient supplementation, and general aspects of nutritional support in catabolism. He also leads very large NIH-funded trials of micronutrient supplementation in Tanzania and India. And one of his big papers came out, I think, last year in the New England Journal of Medicine on the supplementation of zinc. Now, he sounds quite remarkable, and he is, but I really cannot start talking about Chris without touching on my personal experiences with him. And so very briefly, in the 1990s, we met because we were both working as postdoctorals with Professor Vernon Young at MIT in Boston. And Professor Young's lab was pretty much of a pressure cooker situation. It was very productive, very we were all pushed a lot. But that is what really forged a close bond between us. Chris was a young assistant professor at Harvard at the time, working on protein kinetics in Peruvian children. So I just used to look at him with great admiration at the time. We never did write a joint paper together then, but as fate would have it, we do write papers together now, and it's a great experience to work with him. Chris has many avatars, so let me go through some of these. First and foremost, he's a clinician, an active clinician, a pediatric gastroenterologist and nutrition physician at Harvard, at Boston Children's Hospital, and he's currently professor of pediatrics and the director of the Division of Nutrition at Harvard Medical School. He directs the Center for Nutrition at Harvard, where they help infants, children, adolescents, and young adults in a variety of nutritional demands, and his team is rightly considered one of the best in the United States. He is also the medical director of the Center for Advanced Intestinal Rehabilitation, which is very interesting for those of you who are interested in the short bowel syndrome. And this center is one of the largest centers in the US for the care of children with intestinal failure and chronic diarrheal syndromes, and it treats children from all around the world. In what is very relevant to us, his early work has demonstrated the efficacy of oral rehydration solutions for diarrhea management, and he and colleagues authored the first treatment guidelines for diarrhea management in the US. And this was later revised and adopted by the American Academy of Pediatrics for national use. It is no surprise then that he has twice received the Physician Nutrition Specialist Award from the American Society of Nutrition, and was a 2015 recipient of the Formon Nutrition Award from the American Academy of Pediatrics. But in his second avatar, Dr. Duggan is also very passionate about public health and the prevention of disease. And here, his interests range from pregnancy to fetal and child development, physical development, cognitive development. And he is a professor in the departments of nutrition and the Global Health and Population Department at the Harvard T.H. Chan School of Public Health. He has many roles, therefore, at the School of Public Health, but notably performs clinical trials in child development and global health, and these are numerous. But with colleagues in Tanzania at the Muhimbili University of Health and Allied Sciences in Dar es Salaam, he has evaluated the efficacy of nutrition, micronutrient supplements in children, infants and young children born to women with or at risk of HIV infection. And these were very large trials recruiting 5,000 infants in urban Dar es Salaam. And his recent studies are even more close to what we would be interested in, because it is in the development of new biomarkers of environmental enteric dysfunction, which is of interest to us. He also has seminal work on the evaluation of nutritional status on neurodevelopment, and is a lead author of a highly quoted study on the effect of maternal vitamin B12 supplementation on child cognitive development. So he's been funded from a lot of places, including the US NIH, the Gates Foundation, and the WHO. But that's not all. In his third avatar, as I like to say, he is also a great teacher. And there are many in India who will testify to this after they have attended the Bangalore-Boston Nutrition Collaborative course. He was the course co-director with this, and I'm sharing a picture at this point. I hope you can see that. He was a course director for this with Rebecca Curry and Raj at St. John's, and they raised funding for this course, which was entirely free. And it had a superstar international faculty from Harvard, Tufts, and from St. John's and other Indian places. And but that was not enough for Chris, of course, because he's also the course director for the Harvard College course on nutrition and global health. And he mentors undergraduate, graduate, and postdoctoral students at both at Harvard Medical School and the Harvard School of Public Health. I'm proud to say he's also an adjunct professor at St. John's and an honorary lecturer at Muhimbili in Tanzania. He's also been a visiting professor in China and many other countries. But he's much more than all this. If you think this is all, well, let me put the cherry on this cake. And in 2019, he was named the editor-in-chief of the American Journal of Clinical Nutrition, which is the top-rated peer-reviewed journal in the field of nutrition. And during his short tenure in the last 2 years, its impact factor has already begun to rise. So let me end by saying it is really nice to see Chris all dressed up in a nice suit. And I'm sorry, Chris, I've not been able to match you, but it is wonderful to see you, an international leader in clinical and public health nutrition, an editor at the forefront of thought and practice in nutrition. And that is really what he's going to be talking about today, something that really strikes at the very root of philosophy of what we do in nutrition. He's a man who's retained his warmth and kindness at the Olympian heights that he now resides in. And he's a global citizen for me, and I'm really proud to be his friend. Chris, thank you for accepting this. And I do want to tell all our friends who will be listening to you that really what you're touching on today is something that all of us should think deeply about. It's not just race, but also caste and the million other ways that we segregate ourselves as humans. So thank you for doing this brilliant lecture. Over to you. Sorry, before I say over to you, I think part of this is that you must now be presented with the medal. So hold your horses, Chris. You still have to be presented with the medal. Over to you, Subha.
It's a virtual presentation.
It's a real medal being presented virtually.
Congratulations.
Thank you.
Congratulations. This is the gold medal here, and on either side it is flanked by silver twigs.
Very nice.
It will be sent by post very safely.
Thank you so much.
That's a citation.
Certificate, yeah.
This is a
This is
certificate.
the certificate. Professor Christopher, I hope you can see this.
I can't quite read it, but it looks beautiful.
Congratulations once again. Thank you for accepting our invitation. Thank you so much.
Thank you. Thank you so much. Thank you. Should I start with sharing my screen? I guess.
Now, Professor Christopher, the floor is yours. You can go ahead with your talk.
Thank you very much. Can I confirm that you're all seeing one slide on the presentation?
Yes.
Yes.
Well, thank you, Dr. Kirpad, for really that very, very kind and over the top introduction and summary of my career to date. And to say that my nomination and receipt of this prestigious award is the highest honor that I've been fortunate enough to receive is no overstatement. The list of previous recipients is extremely impressive, of course. A group of nutrition scientists who I am proud, if somewhat awed, to join as a colleague. I thank you and the leadership of the Nutrition Society of India sincerely for this very prestigious award. And thank you for coming together this afternoon. Of course, the disappointing aspect of this afternoon's discussion is the requirement that it be given remotely and electronically instead of in person. I had very much looked forward to meeting old colleagues and making new acquaintances in this my second attendance at the Nutrition Society of India's meeting. But certainly the timing of this award and the virtual meeting format that has been mandated by the COVID-19 pandemic gives us all an opportunity to critically review the importance of nutrition specifically and public health more broadly in today's world. Indeed, it has been recently stated that one potential silver lining of this terrible epidemic has been the recognition of the critical importance of public health, of scientific literacy, and of engagement of our political leaders with us as scientists. Many of us, both in the United States and India, have witnessed firsthand the untold suffering and human cost of this pandemic. These losses have been distributed in an unequal geographic, if wide manner, in both countries, and we are currently racing to the bottom in total cases if these data are firm. Unfortunately for both of us, these losses and hardships have been compounded by the failure to appreciate the dynamics of an infectious disease outbreak, the susceptibility of various communities to a viral infection against which pre-existing immunity did not exist, and a short-sighted, egocentric, and what some have termed hyper-nationalistic response that led some leaders to discount or ignore critical public health recommendations. I hope these trends have been, or soon will be, reversed. Now, I'm far from being a professional politician, nor am I an expert in the social determinants of health and disease, but I do want to take this prestigious opportunity to reflect with you about the role of society in health writ large. I can think of no better field than our shared field of nutrition to consider how our two countries' shared history in grouping and categorizing individuals along racial or caste lines has had an effect and continues to have an effect on health and nutritional status of our populations. And in doing so, I hope that these lessons, as well as the lessons of the pandemic, can be brought to bear to improve maternal and child health globally. So please allow me, if you will, an opportunity to discuss the topics of race and caste as a confessed amateur before returning to a more scientific discussion, more familiar to many in the audience in both topic and format. Well, Anura, not noted in your very nice summary of my training and experience to date is the fact that my career in child nutrition and gastroenterology was in large part inspired by several formative experiences I had as a medical student with the Johns Hopkins professor of pediatrics, who, like Dr. Gopalan, was a son of Madras, Dr. Mathuran Santoshan. Dr. Santoshan took me on as an inexperienced, if earnest, first-year medical student to work on a trial of oral rehydration solutions on the White Mountain Apache Reservation in White River, Arizona. It was there that I learned about the physiology of oral rehydration solutions, about sodium glucose co-transport, but also about the huge impact that diarrheal disease has on child health, and about the role that water safety and food insecurity has on human health and disease. More fundamentally, however, I learned about the broader theme of the social determinants of disease, wherein people worked, raised families, were housed, were educated, received medical care, and had so many other aspects of their lives determined, all solely based on their categorization along racial lines. Indeed, the history of the United States is marked by an explicit legislative and regulatory approach to formalize the empowerment of one group of racially defined people over another. Some make the mistake of noting that this caste-based system was perhaps an anomaly in the founding of a country dedicated, quote, to liberty and justice for all. But a brief review of our founding documents points otherwise. The Declaration of Independence of the United States famously refers to, quote, all men are created equal, who are given rights, quote, to pursue life, liberty, and happiness. But of course, enslaved people were explicitly denied those rights. The Second Amendment of our Constitution regarding, quote, the right to bear arms was not solely designed to allow soldier civilians to defend their newborn country, but for slaveholders to prevent revolts. Of course, the same constitutional convention led to the infamous 3/5 compromise, wherein our country's founders decided to count 3/5 of each state's slave populations towards the total state population for the purposes of apportioning representation to Congress. The Dred Scott decision of our federal Supreme Court institutionalized a separate but equal doctrine for decades. All of these statutes were explicitly designed to maintain one group's ability to subjugate another. In her 2020 book entitled Caste, The Origin of Our Discontents by Isabel Wilkerson, the author points out numerous aspects of this organizing principle of modern US society and notes the three important examples include the centuries-long US experience with enforced slavery and resultant Jim Crow segregation laws, the briefer, if harsher, Nazi racial segregation laws that culminated in the Holocaust, and the long history of caste delineation among social classes in India. Now, I should note that although I am a professor at Harvard, I am not a Boston Brahmin and do not share the outlook of my predecessors at Harvard, such as President Eliot, who, among other things, was a proponent of eugenics and restricted immigration. Indeed, as a US citizen, and perhaps more pertinently as an Irish American, I am more politically, philosophically, and culturally aligned with a country like India that also revolted against British rules. Wilkerson states the following in vivid terms. In the American caste system, the signal of rank is what we call race, the divisions of humans on the basis of their appearance. In America, race is the primary tool and the visible decoy, the front man for caste. Race is what we can see, the physical traits that have been given arbitrary meaning and become shorthand for who a person is. Caste is the powerful infrastructure that holds each group in its place. Wilkerson's book also recounts the month-long visit that Martin Luther King Jr. and his wife Coretta Scott King made to India in 1959. Quote, "To other countries I may go as a tourist, but to India I come as a pilgrim," King famously noted. One afternoon, the Kings traveled to Trivandrum, where he spoke at a high school for students in the lowest caste. "Young people," the principal introduced him, "I would like to present to you a fellow untouchable from the United States of America." King later wrote, "We were surprised and delighted to see that India has made greater progress in the fight against caste untouchability than we have made here in our own country against race segregation. Both nations have federal laws against discrimination, acknowledging, of course, that the decision of our Supreme Court is the law of our land. But after this has been said, we must recognize that there are great differences between what India has done and what we have done on a problem that is very similar. The leaders of India have placed their moral power behind their law. From the prime minister down to the village councilman, everybody declares publicly that untouchability is wrong. But in the United States, some of our highest officials decline to render a moral judgment on segregation, and some from the South publicly boast of their determination to maintain segregation. That would be unthinkable in India." Of course, many other examples of racial profiling, racist policies exist, including the apartheid regime in South Africa, the East African slave trade, and the Spanish Inquisition. The point of my speaking today, however, is not to embark on an extended history lesson, but to remind ourselves that today's double burden of disease might not be solely the coexistence of acute infectious illnesses with chronic non-communicable diseases, or even more broadly, the coexistence of high rates of undernutrition with high rates of obesity and overnutrition. But instead, it could be considered as the coexistence of an infectious disease pandemic in the setting of widespread systemic racism or casteism. Instead, my thesis is that while explicit and even explicit or even implicit racism and casteism are generally felt to be abhorrent, similar degrees of concern are not routinely raised when one is faced with data to confirm that the nutritional and health statuses of women and children in our world also suffers systematically. Let me repeat this. Explicit and implicit racism and casteism are generally felt to be abhorrent, but similar degrees of concerns are not often raised when one is faced with data to confirm that the nutritional and health status of women and young children in every country of our world suffers systematically. Indeed, this challenge of defining racism or casteism only based on egregious examples of violent or extreme behavior, think of the video of police dogs and fire hoses trained on civil rights protesters, or the specter of state-sanctioned violence on the current day, brings up the classic problem of the, quote, false dichotomy so well described in the book White Fragility by Robin DiAngelo. If we define racism solely as cruel, vicious acts, then all right-thinking moral people would certainly condemn these. And by standing on the other side of this divide, one automatically counts oneself as non-racist or even anti-racist. Not only is this dichotomy, racist is bad, all else equals non-racist and therefore good, patently false, but it leads to a scenario where the discussion can just end. How can I be a racist or say benefit from racist policies or institutions when I reject such abhorrent activities? The good-bad frame is a false dichotomy. All people hold prejudices, especially across racial lines, in a society deeply divided by race. I can be told that everyone is equal by my parents, I can have friends of color, and I may not tell racist jokes. Yet I am still affected by the forces of racism as a member of a society in which racism or casteism is the bedrock. I will still be seen as white, treated as white, and experience life as a white person. In a society in which race clearly matters, our race profoundly shapes us. A recent example of how the concept of race is commonly handled in the nutrition literature was published in the AJCN in September 2020 by Shaipalo and Wong. Using decades worth of data from their body composition laboratory at Baylor College of Medicine in Houston, Texas, these authors proposed, quote, normative reference curves for white, Black, and Hispanic youths. Total body water was measured by deuterium oxide, and total body potassium was measured by potassium counting. Race was assigned by parent report. For both boys and girls, the fat-free mass index, which was the calculation of fat-free mass divided by height squared, was higher in children described as Black versus those who were described as white or Hispanic. The authors wrote, in general, this report further supports the premise that race/ethnicity specific growth references are needed for accurate growth and health assessment in children. An accompanying editorial by Jonathan Wells called attention to this phenomenon by stating, quote, the authors propose that evaluating health and nutritional status relative to children of similar, quote, race, ethnicity increases the accuracy of the assessment. This approach allows us to move away from the idea that there is a single nutritional norm and that any one population represents this norm. But in acknowledging such population differences, it quickly becomes clear that the language used to describe them profoundly affects how they are conceptualized, and that this is not simply a semantic issue, but also influences how clinical and public health practice affect health outcomes. Wells, I, and other colleagues, including Anura Kirpad, wrote a follow-up piece in which we reviewed the history of using race to categorize people, the lack of biological rationale to group people along racial categories for nutrition studies, since genetic studies do not support this practice, the tendency to erroneously conflate race and ethnicity, the shortcomings of how race is measured and reported, which also calls into question its validity, and the fact that race is a very important but not the only social determinant of disease. Most importantly, we do not say that race, or for that matter, caste or social class, was unimportant in considering health and nutritional status, in that experienced racism or casteism likely plays an important role in disparity-related health outcomes, for example, via access to healthy air, water, food, housing, employment, etc. We strongly recommended that language, diet, culture, and other important aspects of the population under study be better described, so that these important concepts so that they be better described, so that readers, as well as the possibility be considered that certain subgroups may be more or less susceptible to the interventions or relationships under study. A number of other authors have made similar points in the general medical literature. Well, as I mentioned earlier, I'm not an expert on these topics, but in addition to them striking a chord in my role as a citizen, these concepts also hit home in my role as a physician scientist with a focus on maternal and child health. In an analogous fashion, it is one thing for me as a white male physician from a high-income country to publicly, in lectures, editorials, teaching sessions, highlight marked health and nutritional disparities in low and middle income countries that largely affect women and children of color. But how does my role as such an individual play into the perpetuation of a system that maintains social health inequities and that favors physicians and scientists of high-income countries as it relates to securing funding, performing studies, and publishing papers? We all can and must do better to recognize and reduce these inequities. So let me pivot from the sociologic and historical aspects of my talk and speak instead to more familiar topics and how we as committed nutrition scientists can work together to improve the well-being and health of women and children. A highly cited and influential series of studies published in The Lancet in 2008 described interventions for maternal and child undernutrition and survival, for which the data were felt to be very supportive of their efficacy and effectiveness. These included a number of nutritional interventions for mothers, including iron, folate, micronutrient supplementation, as well as iodine fortification, calcium supplementation, etc. Likewise, the promotion of breastfeeding, improved young infant complementary feeding, hand washing and hygiene interventions, the treatment of severe acute malnutrition, as well as zinc and vitamin A supplementation programs were all thought to be helpful to improve mother and child vital and nutritional status. However, buried deep in the paper on table 15, the authors performed a modeling evaluation to determine how impactful a combination of all of these interventions could be on the prevalence of chronic undernutrition, i.e. child stunting. With 90% coverage for all of the interventions, stunting was predicted to be reduced by 32%. And with 99% coverage, stunting was only felt to be reduced by 36%. So indeed, a corollary of this important study was that with near universal coverage of our most evidence-based therapies and preventive approaches, nearly 2/3 of the world's prevalence of chronic undernutrition could not be prevented. So these and other papers reinvigorated the approach to investigate whether chronic subclinical intestinal inflammation could be a factor in the refractory nature of childhood stunting. In one influential study from rural Zimbabwe, caretakers were observed closely, and their homes, hands, and environment underwent bacterial culture. Not surprisingly, disposal of infant stool matter took place in an open pit for nearly half of the households, and E. coli was cultured from the caregiver's dominant hand in 50% of the households, 73% of the kitchen doors, and of course, 100% of chicken feces. 3 infants in the study were noted to be actively ingesting chicken feces, and the authors estimated that such dietary exposure would lead to many millions of bacteria eaten daily. Sadly, inadequate disposal of waste and the provision of safe food and water plague many millions of people globally, as seen in this picture. Well, our research group and others have therefore pursued the concept of environmental enteric dysfunction, in which an inflammatory infiltrate of the small bowel is associated with sometimes subtle changes in small bowel histology, including lamina propria inflammation, villus atrophy, and crypt hyperplasia. Measures of intestinal permeability are altered in this condition, as well as a variable degree of intestinal malabsorption. Of note, the previously used term environmental enteropathy is no longer favored, since it seems like important changes in small bowel physiology may occur before obvious histologic changes. Also of note in this concept of EED is the likely finding that this inflammatory status is primarily triggered by exposure to a variety of enteropathogens, that a spectrum of functional and histological changes can exist, and that these features may progress or regress over time. In addition, a number of candidate biomarkers have been proposed for EED, including the lactulose mannitol ratio, stool markers of both inflammation and increased intestinal permeability, and concentrations of specific and general markers of inflammation. Our own approach has been driven by the recognition that immunologic responses to components of gram-negative bacteria are measurable in the bloodstream. You will remember that gram-negative bacteria are able to be mobile via the actions of the filamentous structure flagellin. In addition, lipopolysaccharide is a key constituent of the outer membrane of many gram-negative bacteria. So-called endotoxin is a major trigger of the inflammatory response to bacterial sepsis, and indeed, endotoxin infusion has been used as a model for metabolic changes observed in the setting of bacterial sepsis. Our colleague, Dr. Andrew Gewirtz, has pioneered a test for antibodies to flagellin and lipopolysaccharide in the setting of chronic gastrointestinal illnesses, also marked by increased permeability and chronic intestinal inflammation, namely inflammatory bowel disease. These data confirm that serum concentrations of these antibodies were higher in the setting of small bowel disease, as seen with Crohn's disease, compared to controls, or compared to patients whose inflammation was limited to the colon, such as with ulcerative colitis. Similar findings were noted in adults with short bowel syndrome, another condition marked by malabsorption and increased intestinal permeability. We therefore hypothesized that these biomarkers could help us better define the occurrence and natural history of EED in our cohort of young children in Tanzania. As a secondary analysis to a randomized micronutrient trial completed there, we had collected blood samples at infant ages 6 weeks, 6 months, and 12 months. Infants underwent detailed anthropometric measurements on a monthly basis through 18 months of age. Our exposure variables included measures of gastrointestinal surface area and absorption, measures of mucosal permeability, and measures of the acute phase protein response. Outcomes included infant growth and neurodevelopmental status. Of 2,400 infants enrolled in the parent trial, we selected 590 infants who met the following inclusion criteria: a length for age z-score of greater than -2 at 6 weeks of age, blood samples available at 6 weeks and 6 months of age, at least one outpatient nurse visit completed, and preferentially those infants who had completed at least one measure of Bayley scales of infant development at 15 months of age, and we excluded any infant with HIV infection or exposure. Baseline maternal characteristics included moderately young maternal age, limited formal education, and limited independent income. Food expenditure and household possessions were also modest. Baseline infant characteristics, because the sample was selected to be free from stunting at age 6 weeks, was generally good, with a low rate of low birth weight, prematurity.
Yesterday I thought you asked class. I thought you asked class.
Anthropometric values at age 6 weeks were all close to average of the World Health Organization standards. After IRB approval was obtained for another secondary study, any infant born to 12 months with excess blood samples in the Boston Children's Hospital Central Laboratory was eligible for inclusion as controls. Subjects were excluded from participation in this research study if their length or weight was 2 standard deviations above or below the mean, or if no growth data were available, if there was evidence of recent fever, or there was any evidence of systemic illness. Well, the growth patterns of the infants enrolled in this randomized trial in Tanzania unfortunately demonstrated a substantial drop-off in both length for age and weight for age z-scores from study entry at age 6 weeks until 18 months of follow-up. At study conclusion, the mean length for age z-score was -1.1, and the mean weight for age z-score was -0.61. Our analysis of these EED biomarkers and subsequent growth were published in the AJCN in 2016 and revealed that significant differences existed between infants born in Boston versus those born in Tanzania. Flagellin IgA antibodies in Tanzanian infants at 12 months of age were significantly higher than Boston infants at roughly 9 months of age. This pattern was even more prominent when flagellin IgG concentrations were measured, in that infants in Tanzania at 6 months of age had higher evidence of EED than the Boston control infants at 9 months of age. Similar patterns were noted for IgA concentrations of lipopolysaccharide, as well as IgG concentrations of lipopolysaccharide. When we examine the relationship between these markers drawn at 6 weeks of age with subsequent growth, a strong relationship was noted between higher concentrations of these biomarkers and the development of underweight, as defined by weight for age z-score of less than -2. This relationship, in which infants in the highest quartile of antibody levels were compared to those in the lowest quartile, confirmed that even when controlling for child sex, preterm birth, maternal age, education, mid-upper arm circumference, number of household assets, study regimen, and anthropometric z-score at 6 weeks of age, there was still a doubling of the risk of subsequent underweight. In another analysis in this cohort, we evaluated the relationship between EED as measured in early infancy with measures of neurodevelopment as measured at 15 months of age. As shown here, cognitive development, as measured by the 3rd edition of the Bayley Scales of Infant Development, was positively associated with higher serum concentration of antibodies to bacterial components. Neurodevelopmental assessment of receptive language and gross motor skills, however, were not associated with these biomarkers. Instead, we found a significant relationship with the amino acid citrulline, a marker of gastrointestinal mucosal surface area, and receptive language and gross motor skills. All of these correlations were adjusted for the study arm of the parent randomized trial, as well as a number of important potentially confounding factors, including morbidity, breastfeeding status, growth, and iron deficiencies. Finally, we also performed a long-term follow-up study among children who had been studied as infants. Many are familiar with the concept of the developmental origins of health and disease, previously termed the Barker hypothesis. We were able to identify and consent the families of 113 children for whom we had detailed infant data. Not surprisingly, there was a strong and significant correlation between length for age z-score at 6 weeks of age and height for age z-score in early childhood. This significant relationship was also observed for BMI z-score parameters. But what was surprising to us was a strong and significant relationship shown here between markers of EED in early infancy, including IgA concentrations to flagellin, and both diastolic and systolic blood pressure in childhood. Future studies should investigate the possible mechanistic links between intestinal inflammation, increased permeability, and cardiometabolic risk in adulthood. We've performed a series of additional studies where we have examined the relationship of these biomarkers of EED with other important maternal and child health outcomes. In this study performed in rural Uganda, we discovered a significant relationship between longer pregnancy gestation and lower concentration of antibodies to lipopolysaccharide when drawn early in pregnancy. This would imply that the subclinical inflammation, which is a presumed component of EED, may relate it to preterm birth. In addition, significant, if weak, correlations were noted between maternal EED and infant birth length, as well as length for age z-score at birth, controlling for maternal age, height, blood pressure, education, and parity status. Of note in this study, pregnant women were also tested for measures of intestinal permeability by what has been termed the gold or perhaps bronze standard test, namely the lactulose-mannitol ratio. In this cohort, no relationship was found between lactulose-mannitol ratio and gestational age or any of the infant anthropometric parameters, lending credence to the hypothesis that other measures of EED besides lactulose-mannitol may yield important insights into the manifestations and natural history of EED. Well, I mentioned previously that numerous biomarkers have been proposed to assess EED, and that these can be broken down by categories of intestinal absorption and permeability, enterocyte mass and function, inflammation, and microbial translocation and immune activation. Data from a cohort of 18-month-old children followed in a trial in Bangladesh found that 39% of children had evidence of increased intestinal permeability, and that stool markers for intestinal inflammation were elevated in 55 to 100% of the cohort. However, the authors confirmed a widespread lack of correlation between lactulose-mannitol ratio and a number of purported EED biomarkers. Pearson correlation coefficients range from 0.15 to minus 0.08. And indeed, the highest concentration among the 13 biomarkers was between two measures of the acute phase response, C-reactive protein and alpha-1 acid glycoprotein with an R value of 0.55. It therefore seems likely that no single biomarker can adequately capture the various components of EED. We and others are pursuing a combination of biomarkers to better describe this phenomenon. Further, the lack of an agreed upon case definition and diagnostic criteria for EEDs needs rectification. Although the relationship between EED and impaired child growth seems strong, its relationship with birth outcomes, micronutrient deficiency, and perhaps even long-term cardiometabolic health needs to be further assessed. We and others are pursuing studies of EED during pregnancy, and numerous investigators are evaluating the relationship between various biomarkers and small bowel mucosal biopsies. We await these results with great interest. But it would be unfortunate for me to conclude this oration with skepticism about our ability to firmly pin down the role of EED in contributing to important outcomes in maternal and child health, to say nothing about pessimism on the role of race or caste in our society. Like racism, stunting is a multi-layered phenomenon unlikely to be eradicated by a single intervention. An updated version of the Lancet series confirms that steady progress has been made with respect to stunting and wasting prevalence in low and middle income countries. In low income countries alone, stunting prevalence in children under age 5 has been reduced from 40% in the year 2000 to 32% in 2015, an impressive decline, but still an impressively high prevalence. Graphically, mean height for age in the first 5 years of life has also shown a notable improvement, i.e. less of a decline since birth. In both low-income countries, noted by the solid lines, as well as middle-income countries in the dashed lines. However, social stratification of these improvements is also quite evident in that child height for age z-scores in the poorest quintiles of families in the low-income countries still persist on average to be 2 standard deviations below the median, and that there is rough comparability between children in the poorest quintile of middle-income countries compared with the children in the wealthiest. On the prevalence of low body mass index among women ages 15 to 49 years. Such graphical representations of these data is helpful to target resources for these persistent problems. Finally, I would like to point to you a series of papers recently published as a supplement to the AGACN, wherein a variety of methods were used to evaluate how countries successfully reduce the prevalence of childhood stunting. Recognizing that stunting is a complex phenomenon, these authors performed 4 types of inquiries, including systematic reviews of published peer-reviewed as well as the so-called gray literature, retrospective quantitative data analysis of demographic and health surveys, a review of key nutrition-specific and nutrition-sensitive policies and programs, and qualitative data collection and analyses, including interviews with key stakeholders. Shown here are data showing a sustained reduction in stunting prevalence in Nepal from approximately 70% in the early 1990s to less than 40% in 2016. These figures are in concert with several other countries in South Asia showing steady reductions in stunting prevalence, including India, Pakistan, and Bangladesh. Using their multimodal methodology to tease apart the reasons for this reduction in stunting, the authors concluded that a variety of nutrition-sensitive and specific factors were at play in Nepal. Perhaps most striking in this figure is the outsized role that caretaker education was thought to play in improving childhood nutritional status. Notably, economic improvement was estimated to play a role of less than 10% in reducing stunting prevalence. Birth spacing, reduction of open defecation, and maternal nutritional status improvements were also important factors. Recent data from the Lancet confirm that various factors in various settings have an impact on the reduction of chronic child malnutrition. This figure notes that maternal and newborn care related interventions in Rwanda have been identified as the most important factors there, whereas maternal nutritional factors seem to be more important in Peru, and poverty reduction more important in Vietnam. Not surprisingly, variations in stunting reduction, as well as the relevant attributable factors, vary widely among different states in India. And what about the problem of racism or casteism? What is needed here? Well, similar to stunting, another multi-layered complex phenomenon, simple solutions are unlikely to work. Such simple solutions, often provided in what counts as discourse around race, have been reviewed by Robin DiAngelo in her book. I was raised to treat everyone equally. I don't see color or caste. Focusing on race is what divides us. I lived among the fill-in-the-blank people, so basically I'm a person of color. Well, here is one possible solution, or at least an illustrative story. In December of 1932, one of the smartest men who ever lived landed in America on a steamship with his wife and their 30 pieces of luggage as the Nazis bore down on their homeland of Germany. In America, Einstein was astonished to discover that he had landed in yet another caste system, one with a different scapegoat caste and different methods, but with embedded hatreds that were not so unlike the one he had just fled. He became a passionate ally of people consigned to the bottom. He hates race prejudice, W.E.B. Du Bois wrote, because as a Jew, he knows what it is. So my concluding advice for this oration, my prayer, if you will, from the Latin orare, to speak or pray, is that we channel our inner Einstein, to meet the people in our lives with true empathy and a will to understand their circumstances, to work in true collaboration with them to better these circumstances, and to work as nutrition scientists to tackle the important problems of health and nutrition inequity, which plague so many people in so many places. To again quote Isabel Wilkerson, a caste system persists in part because we, each and every one of us, allow it to exist. If enough people buy into the lie of natural hierarchy, then it becomes the truth or is assumed to be. There are people of personal courage and conviction, secure within themselves, willing to break convention, not reliant on the approval of others for their sense of self, people of deep and abiding empathy and compassion. They are what many of us might wish to be, but not nearly enough of us are. Perhaps once awakened, more of us will be. Thank you for this opportunity to address your society and our global society on these important topics.
Congratulations. Excellent talk, Professor Christopher.
Thank you.
Go to questions.
Yeah.
Clarification.
Oh, Madam will answer.
So, can we put some questions? Dr. Subbarao is here. He'll be taking the questions which are there on the chat box. If you're ready, we'll initiate.
Please, please. I welcome questions.
Thank you for that excellent talk, Professor Christopher Duggan.
Thank you.
There's a question from a participant, Dr. Venkatesh, who says, over recent decades, there has been a change in the concept of international health in the US institutes. It has moved from health in developing countries. This is perhaps due to public health challenges, including emergencies affecting all countries alike. Now, even in developed countries, we have much to learn from experiences of developing countries. What are your views on this?
Oh, I couldn't agree more with Dr. Venkatesh. Indeed, as I mentioned earlier, I cut my teeth on the importance of oral rehydration solution, which as you know, was described as a reverse transfer technology. Oral rehydration solution was first really discovered in important field sites in West India and what is now Bangladesh, of course, and its proof of concept there during cholera epidemics really revolutionized child care for diarrheal disease around the world, and that was to prove that point quite explicitly, but I think that was a long time ago. And I think nowadays there's no end to the science and excellence coming from many countries in the world. Anura mentioned that I recently took over the reins of the American Journal of Clinical Nutrition, and thankfully I've engaged him and other global leaders in the field of nutrition to really bring out the best of science from many different countries. So I appreciate the comment, Dr. Venkatesh.
There is another question. This is related to the role and significance of food sensitivity in health, in social health, due to impaired intestinal and systemic health and malabsorption and malnutrition. And so development of several chronic diseases issues, chronic health issues also take place. So what's the role and significance of food sensitivity?
By food sensitivity, is the questioner asking specifically about the role of food allergies, perhaps?
Perhaps.
Perhaps
Yeah,
they are
perhaps,
asking
yes.
the role of food sensitivity, probably allergenicity in EED, probably.
Yeah, I would have to say it's very much under investigated in most low and middle income settings. Unfortunately, there is this, of course, very commonly referred to hygiene hypothesis, in which children perhaps with a higher incidence of what we're terming EED perhaps have a lower incidence of autoimmune type immune responses, including diseases such as Crohn's disease, a variety of food allergies, and dermatologic conditions, including eczema, and as well as reactive airway disease. But as you well know, in the cities of India, there's many populations who are living lifestyles that are very comparable to Boston, New York, and London, and the incidence of diseases such as inflammatory bowel disease and food allergies is certainly on the rise.
Yeah, thank you. There is one more question, which is more of a comment. It talks about the SDG of zero hunger by 2030. Can it be a reality, or is it just a rhetoric? Is it achievable, is what the question is.
I sure hope it's achievable. I would relate that the upcoming UN Food Summit would be a good place for people interested in a report card on the Sustainable Development Goals. We just hosted a symposium here at Harvard on the general principle of climate-related nutritional goals that I hope a report on that will be coming out soon. But I am optimistic that safe water and safe food are increasingly available, and I think we have to maintain our sense of optimism as we shoot for these very important goals.
I have one comment here. This EED can be driven by a complete cereal-based diet with very little vegetables and fruits in it. Means high carbohydrate diet or very high fat diet. Even these diets can drive enteric dysfunction.
That's an excellent question. The specific role that diet has had to the pathogenesis of EED has also been under-investigated, because certainly in our studies, we look more carefully at duration of exclusive breastfeeding and the role of these EED biomarkers. And as you might imagine, those children who were not breastfed as long, or who did not receive immediate breastfeeding immediately after birth, had higher concentrations of these biomarkers. But the specific foods in older children that are associated with EED has not been well teased apart. Excellent area of investigation. There are some data to suggest that high-fat diets, saturated fat foods do lead to increased intestinal permeability. So what was suggested in the question is an excellent route.
Because they cause dysbiosis and then followed by...
Well, you noticed I didn't use the word microbiome. And again, I think that's an area of science where we've learned a lot and continue to learn things, but its role in the pathogenesis of EED is, I think, still to be determined.
One last question.
There are two, in fact, and I will not take after that. There are two last questions. One is about how LPS and flagellin antibodies correlate with serum CRP and AGP in young children.
In one of our studies that I didn't have time to cite, we did notice an important correlation between those two. We also noted correlations between CRP and growth, even taking into consideration some of the EED biomarkers. So they're certainly, as you know, CRP and ESR are related to the amount of immune globulin concentrations in the body. So it's not a surprise that higher measures of acute antibodies would result in higher measures of acute inflammation more systemically. So yes.
Yeah, one question from Dr. Sharath Gopalan. He is asking, in the context of environmental EEDs and the persistence of nutrient deficiencies in many developing regions of the world, even iron deficiency, for instance, he states, how practical and feasible are nutrient absorption studies, and documentation of intestinal malabsorption in these regions?
Oh, that's a really excellent question. We certainly, and I might even kick it over to Anura to comment, but we really need better measures of intestinal absorption. When you think about it, we've used very gross techniques that have been limited in their sensitivity and specificity for different absorptive capacities. And as Anura mentioned in my introduction, one of the key, scientists in our life was Dr. Vernon Young, who back was 30 years ago. I remember distinctly him saying, in the future, you're going to be able to put a pulse oximetry probe on someone's finger and figure out exactly what their different nutritional status is or needs to be. And I think that promise with the idea of precision nutrition is certainly been highlighted by NIH and other funding mechanisms. And part of that is as mentioned by Dr. Gopalan, the idea of specific and safe and sensitive and effective measures of intestinal absorption. Anura, what are stable isotopes the way forward for that? We can't hear you.
So you have to unmute yourself.
I think he'll type it.
Yeah, can you hear me?
Now we can.
Yes.
Sorry, Chris. Thank you for putting me on the spot. But stable isotopes are a good way for physiology. But I think there's got to be some way forward in terms of measuring these metabolites in the blood directly as a measure for precision nutrition or for broader utility. Stable isotopes, I think, are a bit limited. But that's just me thinking off the top of my head. I might regret saying that anyway. Thanks. Back to you, Chris.
Yeah, there are quite many questions, sir, but due to time constraint, we're not going ahead. I think we invite Dr. Dinesh Kumar, the Vice President of the Society, to propose vote of thanks.
Before we move on to vote of thanks, I would request the past presidents, Dr. Anura and me, Dr. Seshikaran, to tell their remarks on the top.
Yeah, Dr. Seshikaran first, please.
So thank you, and thank you, Chris, for accepting our invitation and giving such an excellent talk. We are always worried about how it will go in this virtual presentation. I think both you and I were worried, and so was Anura. But anyway, all goes well, and thank you so much. And we hope you will have an opportunity to come to India.
I hope so.
Maybe when the COVID goes off, and we could personally give you the award, but I think it won't be possible. So I think the award would reach you through appropriate channels, and I kindly accept it on the behalf of our trust. Anura.
Thank you so much.
Thank you, Chris. It's always a pleasure to listen to you. And I think, the way you went from a very broad topic down to molecular approaches to intestinal disease and then back up into the broader aspects of it was fascinating. And I really think that the future nutrition scientists should be somewhat like you, in that they must engage with the broad social dimensions of what they're doing. So I do think you have really given a great oration, and you follow in the tradition of Vernon Young, who was also a Gopalan orator. So that's good.
Yeah.
For those of you who have not had Chris correct your manuscripts, well, I can tell you he's one of the very tough guys around. But it's wonderful to deal with him. And thank you, Chris. I think cell to society is a theme that should be there in nutrition for all of us. And you showed us that. Thank you.
Thank you. Thank you very much, really, for everyone's attention and participation in today's talk. I'll conclude again to say that it is my desire to be with you in person as soon as possible, and I'll await the green light from Anura and colleagues at St. John's, and I'll be on the plane as soon as I can be. Thank you so much.
Sir, it gives us a great pleasure on behalf of Nutrition Society of India, the 44th GOPALAN Memorial Oration has been given to the professor who has really opened a new challenges for us. In fact, I recall one of the cartoons which has appeared because your first slide was on the COVID, where because of the pandemics for 1.5 years, we could not really listen to anything. And the pandemic cartoon was the globe is under renovation. And we are hoping that our nutrition society was also under renovation. You have opened it up. Thanks a lot. Thanks to audience. Thanks to President Dr. Hemlata, Secretary Lakshmaya, and my office bearers, and all the participants. There were 277 participants were there, and this was a direct live show on the YouTube. Thank you very much, sir, for your great lecture. We will be meeting you soon in India once the pandemic declaration is over. Thank you.
Thank you, sir. Thank you. Thank you.
Thank you very much. Thank you. Thank you. Thank you so much.
Thank you, everyone.
Thank you.
Thank you.